Good afternoon. My name is Jenn Vitulli, and I'm very excited and pleased to present to you today a continuous improvement model adapted from the Cleveland Clinic, which I believe can positively impact a variety of healthcare organizations. When the Cleveland Clinic was founded in 1921, it focused on three main areas: improved patient outcomes, enhanced research, and implementing extensive professional training. These focuses gave the clinic a platform on which it can build an improvement model. It was formalized as one of the very first healthcare improvement models in the United States, and its success was supported by being widely recognized as one of the best hospital systems in the United States. In addition, the organization has over 65,000 employees, spanning both the U.S. and internationally. That success is supported by the numerous studies that seek to define and create replicable models of what the Cleveland Clinic has developed over a century. Here we see the Cleveland Clinic's improvement model that has been refined to the point where it can be represented graphically as a system. The slide shows how the CCIM is presented by the organization. The Cleveland Clinic's improvement model is primarily focused on organizational alignment, meaning that individual and team-level goals are connected to the organizational goals. Visual management, which is technology and feedback loops to provide employees with metrics and processes. Problem solving, alignment and metrics contributing to the problem-solving process. And standardization. Problems contribute to improvements and development of new effective routines as solutions are developed. Despite the success of the CCIM model, its applicability as a replicable model for other U.S. healthcare entities is limited. First, the model developed is to meet the particular needs and goals of the Cleveland Clinic, which are unique. Two is that the model relies heavily on long-term development of human technical and human resources, which can be difficult for other healthcare entities to put into place. And lastly, CCIM's multi-layered complex model might be hard for smaller entities to actually replicate, which is the majority of U.S. healthcare industries. To fully understand the strategic initiatives of the CCIM, one must grasp how the model defines its goals. The essential factor in goal setting within the CCIM is that the enterprise-level goals are broken down into sub-goals at the executive level, the management level, and the individual team level or local level. The CCIM has had to adapt to a myriad of environmental factors, from economic ups and downs to demographic changes to medical and technical breakthroughs. These changes define the constant need for every healthcare model to address contextual, external, and operational internal goals. The participatory elements of the CCIM are apparent and are possibly the most vital evidence-based elements of the entire model. Every focal area stipulates sharing of goals, metrics, and/or process changes. In addition, meetings and discussions are promoted for transparency and are integral to improving processes. The end result is that the strategic initiatives of the CCIM and its results show how organizational connections can support improving positive healthcare outcomes. Through our study and research, there were other limitations of the CCIM that we found. One is that although it focuses on best in care, there was not enough focus on patient-centered outcomes. It focused more on identifying the outcomes and not on achieving them. The other was lack of focus on cost-effective treatment. The CCIM models doesn't provide clear recommendations on how to reduce the healthcare costs. And lastly, the impact of COVID-19 is not considered, which we obviously know for obvious reasons how detrimental that can be. Ethical considerations of the research also had to be considered in this study. Since the study does involve patient data, we had to ensure that there was anonymity associated with the patient data, and also that we were able to put in safety metrics so that there was no sharing of confidential data. from the financial aspect, although there are federal mandates for the reporting of costs and expenses and insurance fees, we also had to look at why certain data was what it was and reducing to the process of not merely a money issue. However, failing to implement more precise measurement within the healthcare system can be seen as an ethical failure in itself, in the sense of consciously ignoring the benefits of additional insights that can potentially have a significant impact on improving patient care. The findings of the healthcare factors replicability analysis yielded 3 general principles. One was a focus on a subset of healthcare outcomes to gain adequate progress. The model focused on narrowly defined set of outcomes. 2, the measure for outcomes was not accountability. The results are reported per department or division. And lastly, problem-solving efforts should be as frictionless as possible. The CCIM models has resulted in stipulation of reduced set of absolute standards. The critical paths for improvement that emerged from the replicability analysis centered on 3 factors. 1, participation is vital and must always be supported. 2, in similar findings, flatter hierarchies are not easy to implement and require clear definitions. And 3, costs should be weighted against positive patient outcome levels. Our analysis has also identified the following leadership factors. 1, executive power should come from outcomes and not titles. 2, empowerment is the other side of the participatory model coin. Everyone in the organization should use and is expected to use their level of power. And 3, the current pandemic crisis is about healthcare and not corporate politics. The following 3 parameters should be used to foster collaboration. 1 is the improvement model is not evidence-based unless the measures it takes are objective, which means we need to look at KPIs. 2, the primary goals are positive patient outcomes. The evidence must always address them. The effectiveness of collaboration should be measured in relation to positive patient outcomes. And 3, problem solving creates evidence-based practices as often as it follows them. So new solutions created during the pandemic can be used for future evidence-based practices. Our study found that there are 2 major criteria associated with the simplified model. 1 is reliance on fundamental principles within the healthcare industry. And the 2 is the need to identify KPIs to enhance the model's sustainability. The recommended simplified model defines 3 focal areas as launch points for its adopters. These areas are patient outcome levels, resource usage, and improvement cycle rate. These were chosen to frame the simplified model because they target the essential processes needed to plan for healthcare improvement without burdening the organization with a complex series of tasks. Patient outcome levels establish the fundamental driver of the simplified model. It also allows the organization to identify which patient outcome levels are above or excellent and guide further improvements. By looking at resource usage through the healthcare resources as well as organizational resources, we can gain a better understanding between which ones are overextended, underused, poorly or well-funded, and with an understanding that the connections between the 2 are almost certainly where the problems will be defined. The final category looks at the improvement cycle rate, which refers to the short-term and long-term changes and their sustainability within the organization. The major advantages of the simplified model are launch points for collaborative consultation. Additionally, their data can be measured for performance and patient outcomes, which is easily available for healthcare organizations, and no significant time or money investments. Through our research and study, we are confident that this simplified model based upon the Cleveland Clinic's improvement model can effectively be implemented in small healthcare organizations. The model aligns with the needs of healthcare organizations caused by the COVID-19 challenges, and it's easy to understand, implement, and flexible. We hope that consideration will be given to this model so that healthcare organizations throughout the U.S. and abroad can benefit through their patient outcomes. Thank you, and we appreciate your time.